This conference will now be recorded.
నేను పెట్టుకోవాలా మైక్?
అవసరం సార్, డైరెక్టర్ చెప్పారు.
లాస్ట్ నెంబర్ 102 కి 105 కానీ చూపించి 105 నేను వస్తాను. ఎస్, హలో, ఉన్నారా లైన్లో? హలో, ఎంతమంది ఓపెన్ అయ్యారో తెలుస్తుందా మనకి? లాగిన్ అయ్యారు? హలో హలో హలో, nobody is responding. 87 present, sir. Hello, hello, hello.
Yes, sir.
Hello, I am Dr. Rambabu speaking. Today we have to discuss with the renal neoplasms. Okay. Okay. Renal neoplasms are divided into two groups: benign and malignant. So benigns are very rare, malignants are more common in our setup. So what are the benign neoplasms? One is the adenoma, angioma, angiomyolipoma. Okay. The benign tumors again divided into four groups. The tumor which occur in the children, that is called Wim's tumor or nephroblastoma. This is more common in children or infants. In adults, the kidney tumor is called Graves' tumor. The another name for Graves' tumor is also adenocarcinoma hypernephroma. Usually occurs in adults. The other rare tumors are transitional tumors, cell tumor related to the renal pelvis and collecting system like ureters. And the rare one is squamous cell carcinoma of the renal pelvis. Okay, you have to discuss in detail each and everything. First, you have to talk about the benign tumors. So I already discussed it before. Three are more common. One is the adenoma, angioma, and angiomyolipoma. So adenoma, among all the three, adenoma is the more common. It is also called renal papillary adenoma. So where from it arises? Usually it is arising from tubular epithelium, a small discrete adenoma. The size is less than 5 mm in size. These adenomas are more common in cortical region of the kidney. When you cut section of that kidney, it is yellowish color. Sometimes this renal papilloma is a benign tumor. Sometimes it may turn into a malignant, into papillary type of renal cell carcinoma when the size is increased more than 3 centimeters. Usually, you know that it's 5 mm in size. If it is increased in its size, it may turn into the sense of malignancy, like a papillary type of renal cell carcinoma. So this is a specimen showing the renal cell papillary adenoma. This is also one of the papillary adenoma. Multiple small cysts are there, you know. This is the adenoma of the kidney, benign condition. The next benign lesion is the angiomyolipoma. What is angiomyolipoma? It consists of not only the fat but also blood vessels and smooth muscles are present in the histological picture of the angiomyolipoma. This angiomyolipoma usually associated with the tuberous sclerosis in 50% of the cases. So clinically, infant may have spontaneous hemorrhage or hematuria can occur. Whenever hematuria is there, you may suspect the angiomyolipoma. The another benign tumor is oncocytoma. It may ask as a short notes. You should remember. You have to know. You need to know something about the oncocytoma. So oncocytoma usually is a epithelial tumor. Where it is arising from the interrelated cells of the collecting ducts. Collecting ducts means ureters or renal pelvis. These cells histologically, if you see the histologically, the cells are large nucleoli, and eosinophilic cells contains the numerous mitochondria. Usually it is well encapsulated, tan in color and homogeneous appearance on cut section. Sometimes it may attain the large size also. It is a multicentric origin. So a few points you should know about this oncocytoma. Are you understanding?
Yes, sir.
Multicentric origin means it may arise in any part of the kidney. So those are the benign tumors. Now we have to discuss about the malignant tumors. Usually the malignant tumors are uncommon between age of 7 and 40. Before 7 only, usually this malignant tumors occurs in the kidney. After 40 only. Before 7 and after 40. So in between 7 and 40 years of age is uncommon. The malignant tumors of the kidney. We have to discuss in detail about the Wim's tumor. They may ask a essay question for the Wim's tumor and hypernephropathy. In detail, you have to know. What is Wim's tumor? So usually occurs in the children. It is also called neuroblastoma, nephroblastoma. It is a mixed tumor. Why it is mixed tumor? Because it contains the both epithelial as well as the connective tissue. This tumor consists of epithelial and connective tissue. So embryologically it is arising from the nephrogenic tissue. This tumor usually occurs in the first 4 years of the life. This nephroblastoma may occur either upper pole of the kidney or lower pole of the kidney. It is usually unilateral, but occasionally it is a bilateral. Only 5% of the cases, the nephroblastoma is bilateral. So what is the pathology? Pathology, when the gross appearance and microscopic appearance. Gross appearance, this means macroscopic appearance, it is a smooth, soft and fleshy. The color of the tumor is pinkish white, associated with the hemorrhagic areas. These hemorrhagic areas are friable and tends to rapidly growing the tumor. Okay. When you cut section or microscopic examination of the tumor, it consisting of the, we already discussed, epithelial cells and connective tissue cells are there. That is called mixed tumor. In addition to that, there is islands of the bones, cartilage, muscles can be seen microscopically. These are commonly involving the glomeruli and the tubules of the kidney. Some elements are less sensitive to radiotherapy, so may not respond to the radiotherapy when the Wim's tumor developed in the children. That is the macroscopic and microscopic features of the Wim's tumor. So what are the types? There are two types are there, depending upon the involvement of the anaplastic features. So first variety is the favorable histology. That means Wilms tumor associated without anaplastic features. And this nephroblastoma is also associated with anaplastic features. So based on this, they are divided into histologically 3 types: cystic nephroma, mesoblastic nephroma, and nephroblastoma. These are the 3 clinical pictures of the Wilms tumor based on the histological feature. So these are the specimens showing, you see, umbilication is there in the center of this one. These are the hemorrhages and necrotic parts. It's a bilateral tumor, very rare. So it is a multiple irregular bilateral masses. These are left kidney and the right kidney. Okay. There is a picture showing the Wilms tumor in the infants. So what are the clinical features? When the patient developed, infant developed the nephroblastoma or Wilms tumor, what are the clinical features? It can occur in both sexes, male and female are equally affected. There is no variation in between male and female sexes. So it consisting abdominal mass. When you palpate the abdomen, you can feel the mass in the loin. Patient may have a fever because of certain infection will be there, so that patient is running temperature is there. Hematuria because of involvement of the renal parenchyma or the renal pelvis. In 25% of the cases, the blood pressure is reduced, hypotension. The remaining all cases are hypertension will be there. This tumor, Wilms tumor, may be associated with the other anomalies and the syndromes. This is the Wilms tumor. So this tumor, how that tumor looks, it is a grossly, rapidly increasing in its size. Apparently it is a smooth, mobile, formed to hard, lobular, and located in the loin or in the kidney region. It is, if it is in the below the loin, you can it is bimanually palpable. That means upper hand of the both hands, it can be palpable and palatable also, just like a spleen. And dullness, when you focus the renal angles, there is a dullness. But in the anterior part of the abdomen, there is a resonant, because these are covered with the intestines. Intestines may contain some amount of air, so that it gives a resonant on percussion. Another important is it doesn't cross the midline, whereas the other adrenal neuroblastomas crosses the midline from the right to left, but it doesn't go from one side to other side. That is a characteristic feature of the Wilms tumor. And patient may have a fever, maybe due to some tumor necrosis, and hematuria. We already told you this hematuria, how the hematuria can occur because of rupture of the tumor cells into the renal pelvis. If the hematuria is there, the prognosis is grave. How do you stage of this tumor? There are 4 stages depending upon the involvement of the tumor related to the kidney. The stage 1, stage 2, stage 3, stage 4, stage 5. 5 stages are there. What is the stage 1? The disease is only confined to the kidney and easily resectable. That means a small size. If the tumor extends beyond the kidney, that means perinephric region, but it can be excised completely. That is tumor. That means beyond the kidney, the tumor is extends. That is called stage 2. Stage 3 means after the resection, some residual or tumor can occur associated with the positive hilar lymph nodes or para-aortic lymph nodes, and spillage of the tumor cells can occur. That is stage 3. Coming to the stage 4, that is hematogenous spread. So the bones metastasis can occur either to the lung or liver, rarely brain and the bone. If it is a bilateral, that is a stage 5. So bilateral is very uncommon. Okay. So depending upon the involvement of the tumor to the kidney, divided into 5 groups, 5 stages. So this is a nephroblastoma. Histologically, you see the kidney tissue is seen at the right side. Right side means this side is a normal. This is the left side is the tumor. The tumor consisting of the spindle cells and fibrous septa are there, and glomeruli and abortive tubules are present. These are the tubules. That is a histological feature of the nephroblastoma. So what are the investigations to identify this Wilms tumor? The simple and most important investigation is the ultrasound of the abdomen. So by doing an ultrasound, you know which kidney is involved, what is the size, what is the extent. In aortic lymph nodes or para-aortic lymph nodes or hilar lymph nodes are involved or known or not, you can know by doing the ultrasound. Next, intravenous urography or intravenous pyelography that can also reveal the renal tumor mass. Renal angiography, that means the vessels may be involved. That can also be useful to diagnose the Wilms tumor. If you take the plain X-ray of the abdomen, it is axial peripheral calcification is the diagnostic feature. If you take a normal X-ray, plain X-ray of the abdomen, CT scan is very important to know the staging of the disease, where it is extended, how it is the spread, and what are the structures are involved, either cortex, medulla, or renal pelvis. You can know by doing a CT abdomen. CECT means computer enhanced tomography. Next, metastasis. So metastasis usually is a blood-borne. So it may goes to the already discussed earlier. It may metastasize to the lungs and the liver, rarely to the bone and the brain. And lymphatic spread is uncommon. Mainly it is hematogenous spread and local spread. So what are the differential diagnoses? The same features may mimic in other tumors also. That is called the differential diagnosis. So adrenal tumor. How do you differentiate the adrenal tumor? It crosses the midline. But whereas Wilms tumor doesn't cross the midline. Certain retroperitoneal tumors also may mimic the same condition. Any renal cyst in the kidney, that is also one of the differential diagnoses. And polycystic kidneys. Why polycystic kidneys can be considered? Because there are certain, they already shown the diagram, multiple lesions are there, irregular and umbilications of the tumor cyst. That mimics like a polycystic kidney. These are the 4 conditions. Consider them as differential diagnosis. What is the prognosis? So, in the first year of the life, if the Wilms tumor occur, the 5-year survival rate is 80%. But the recurrence rate is very high in Wilms tumor. Prognosis. Certain prognosis factors may also develop responsible for the survival rate of the infant or children. One is the age. If it is age less than 1 year, the results are good. If 3 or 5 or 7 years, that is a bad condition. Bilaterally, if the 2 kidneys are involved, the prognosis is also bad. Size, if it is increased more than 7 centimeters, that also bad prognosis. And hematuria. And tumor spread. Tumor spread, you should remember, I already told you, it is stage 1, stage 2, limited to the kidney. If it is beyond the kidney or bloodborne, that is a metastasis can occur, that is a Graves' disease. Prognostic is bad. So this is the Wilms tumor, you see, hemorrhagic lesions are the lower pole. The tumor arising from the lower pole. Upper pole can also develop. So how do you treat the case? The surgery is the treatment of choice for nephroblastoma. So you should remove the kidney, nephrectomy, that is called. Removal of the kidney is known as nephrectomy. Total all structures along in the tumor, kidney, upper 1/3 of the ureter to be removed. Suppose if it is bilateral disease, if it is upper pole is involved only, you should do partial nephrectomy. Or lower pole is involved, you should do partial nephrectomy. That means half of the, some part of the affected part of the kidney to be removed. Sometimes if it is bilateral, that is called nephron sparing surgery. Means a partial nephrectomy should be done one side, total to be one side, other side. That is called nephron sparing surgery. Radiotherapy, when it is not feasible to do surgery, then you should give radiotherapy and chemotherapy. When you leave the chemotherapy, advanced stage and metastasis can occur either to the lung or kidney, lung, liver, bone metastasis are there. You should do chemotherapy. That is a systemic therapy. Actinomycin D, vincristine, and doxorubicin. These are the chemotherapy drugs may be given to the children. Okay. Next, that is over. Coming to the hypernephroma. It is as a question. Sometimes I am asking in the theory. You should know. You need to know in detail of this hypernephroma. Hypernephroma is a malignant tumor of the kidney seen in adults. Another name is Graves' tumor or renal cell carcinoma. So this is a tumor involving the lower pole of the kidney. It is non-capsulated, no capsule is there, so irregular in outline. This cut section, if you say hemorrhages are there, these are the red color are the hemorrhages, and necrosis associated with the necrosis, and golden yellow color will be seen. This is the golden yellow. And this is the necrotic part, black one. This is a cut section of the hypernephroma. So these renal plasms are also I already discussed. It is hypernephroma or Graves' tumor or renal cell tumor or clear cell tumor. So this renal cell tumor is only adenocarcinoma. 75% cases are adenocarcinomas. Okay. What is the origin of this renal cell carcinoma? It is arising from the renal tubular cells. Most common site is the proximal renal tubule. So renal tubular is commonly it is involved in the proximal renal tubule. Distal means that is come to the ureteric side. So proximal means towards the renal pelvis. So more commonly in males. The common age group of this renal cell carcinoma 50 to 60 years of the adult life. Sometimes it may also arising from the adenoma. I already told you papillary carcinoma, papillary adenoma of the kidney may turn into a renal cell carcinoma. Earlier I told you the benign adenoma may turn into a malignancy if the size is more than 5 centimeters. So it may also arise from the adenoma, existing adenoma. This is another picture showing this hemorrhagic and lower pole is involved. So what are the causes responsible? Etiology is mainly associated with some other conditions like any tumors related to the pancreas or renal angiomatosis and cerebellar hemangioblastoma. So all these together are called Van Hippel-Lindau disease. So these associated with the renal cell carcinoma. Usually in this condition, the renal cell carcinoma is bilateral. The another etiological factor when who consumes the patient, individual consumes high fat diet in animal fat. So the diet contains the animal high fat that may also responsible for the development of renal cell carcinoma. Certain environmental conditions like asbestos factories and lead, cadmium and tobacco also risk factors for the development of renal cell carcinoma. Just cigarette smoking, that also very dangerous. There is a chance to develop the renal cell carcinoma. Sometimes it may be chromosomal aberrations, mutations. Chromosomal mutations may also genetically develop the renal cell carcinoma. Sometimes the cystic kidneys, polycystic kidneys are there. If they are undergo long-term dialysis, that may also turn into a malignancy. Okay. One is the associated with the other diseases like pancreatic tumors, renal angiomas, and high fat diet, and asbestosis, cigarette smoking, chromosomal aberration, and long-term uses of dialysis. So what is the pathology? Pathology means you should write macroscopic features and microscopic features. So what are the macroscopic features? These tumors are usually moderate to large in size. The shape of the tumor is spherical, round. Usually it may occur either upper pole or lower pole. Very rarely in the hilum of the kidney. When you cut the section of the tumor, it is semi-transparent, either yellowish in color or dull white in color. Some lipoid content may be present in the tumor itself. What are the other things you can see on the cut section? So necrosis and hemorrhage already shown, hemorrhagic spots and necrotic parts can be seen in the tumor itself. Sometimes the tumor may be divided into lobules due to the presence of fibrous septae. These lobules may be cystic. Some of them are firm, some of them are hard in consistency. So tumors are usually large shape, size of the tumor may be irregular in condition, irregular in outline. Usually these are encapsulated, non-capsulated. That means uncapsulated tumor is very vascular. The uncapsulated tumors are highly vascular. This is another tumor, renal cell carcinoma. You see, there is a necrotic lesions and hemorrhagic spots. These also are white fibrous tissues. This is another tumor of the renal cell carcinoma. So what are the microscopic features? Macroscopically we have discussed microscopic features. So this common is the solid areas of polyhedral or cubical clear cells. These cells are round in nature, containing the abundant cytoplasm and containing the lipids, cholesterol and glycogen. These cells are sometimes arranged either papillary cyst or tubules. Commonly, less commonly, these cells are granular. That means dark in color. Sometimes containing both dark as well as the clear cells may be present in the same tumor. So it contains the rich amount of the blood vessels. Hemorrhagic spots can be seen. So depending upon the histologically, they can be divided into 4 groups: clear cells, granular cells, spindle cells, and sarcomatoid carcinoma of the renal cell carcinoma. Babu? No, Rajesh? No, Rajesh? Rajesh? So how this tumor can spread? So it may be a local spread, hematogenous spread, or lymphatic spread. So locally, it may spread to the perinephric fat, calyces, and renal pelvis. Blood spread or hematogenous spread, it may go into the lungs or liver or bone. Sometimes it may enter into the renal vein. That is hematogenous spread. Suppose if it goes to the lungs, it produces the cannonballs, secondaries in the lung. Lung balls may have to be affected sometimes. It may go to liver also. It may go to brain also. So lymphatic spread occurs. It may go to the hilar lymph nodes, para-aortic lymph nodes. So depending upon the involvement of this spreading of the tumor, it divided into 3 stages: stage 1, stage 2, and stage 3. So this classification is called Rapson, Flocks, and Cat-Sky staging. What is the stage 1? The stage 1 means the tumor confined to the renal parenchyma. If it is stage 2, the tumor involving the perinephric fat, but not within the, that means beyond the kidney. So perinephric fat is involved, but that is within the gerotic fascia. Stage 3. Stage 3 means the tumor may invade the renal vein or inferior vena cava. Sometimes the regional lymph nodes can also occur in the stage 3. That means both hematogenous spread as well as the lymphatic spread. Sometimes these two can occur. So these are the different stages. This is within the stage 1, within the renal parenchyma. It comes up to the perinephric fat. That is stage 2. Stage 3, it may spread to the renal pelvis or renal vein. Stage 3. Lung metastasis can occur. That is the staging. No, Rapson, Flocks, and Cat-Sky staging, that is called. So according to the American Joint Committee can also given as TNM classification. That means tumor size, involvement of the lymph nodes, and the metastasis. So TX means tumor cannot be assessed. 20 means no tumor, primary tumor has been found. T1 means less than 7 centimeters in size. T2 means it is more than 7 centimeters in size. T3, the involvement of the major vessels like renal vein, renal artery, perinephric fat, and the inferior vena cava, like that. Again, T3 stage divided into 3A, B, C, depending upon the involvement of the tissue. So T3A, intraadrenal or perinephric tissue. T3B, that means involvement of the renal vein or inferior vena cava below the diaphragm. T3 means tumor size is more than 7 centimeters, involving into the inferior vena cava above the diaphragm. T4, so it involves the gerotic fascia, that means beyond the involvement of the kidney, T4. Lymph nodes also similarly, no lymph nodes NO. N1 means regional lymph nodes, that means hilar lymph nodes may be involved. N2 means more than 2 lymph nodes in the hilar region can be involved. M0 means no metastasis. M1 means distant metastasis. That is the staging TNM classification according to the American Journal staging of the TNM classification of the renal cell carcinoma. Now we have to discuss about the clinical features. What are the clinical features when patient have renal cell carcinoma? Coming to the sex distribution, males are more commonly affected than the females because there are certain risk factors, smoking and all these things are there. Next, patient may have a hematuria, so blood in the urine, it is called hematuria. Next, clot colic, because of hemorrhage, some blood may be collected into the bladder that may produce some pain, suprapubic pain, that is called clot colic pain. Sometimes patient may have a discomfort, dragging pain in the loin. So rapidly growing tumor sometimes produces the varicocele. That means the left renal vein, testicular vein, drains into the left renal vein and produces some obstruction in the pamniform plexus, produces the irreversible reduce of varicocele. This mass is in the loin, it is a mobile, nodular in consistency, nodular in surface, hard in consistency, and dull pain present in the loin. So sometimes they may ask you, what is the triad of renal cell carcinoma? So pain, hematuria, and palpable mass, these are the triad of renal cell carcinoma. In the oral, sometimes they may ask you, specimen is when given, they may ask you, what is triad of the renal cell carcinoma means? Pain, hematuria, and palpable mass in the loin. And atypical presentation sometimes may occur in 25%. No clear symptoms has been found. What are the clinical features when tumor produces the secondaries? So if it produces the metastasis to the bones, produces the pathological fractures, and the bony swellings are painful. If it is metastasis to the lung, respiratory system produces the persistent cough and the hemoptysis. Sometimes pyrexia is unknown origin. In such conditions, patient may have running temperature months together. In such condition, you may think it may be a renal cell carcinoma. So PUO can also produces renal cell carcinoma. Certain constitutional symptoms. Constitutional symptoms means lethargy, malaise, weakness, and severe anemia because of loss of blood through the urine, hematuria, may produce the severe hematuria, anemia. Next, polycythemia vera, because of increased this loss of blood, coagulatory factors can be coagulated can occur. Polycythemia vera means clotting can be occur in the blood vessels. Patient may have hypercalcemia, hypertension can be there. Sometimes it may turn into a nephrotic syndrome, very rare. Stauffer syndrome, that means non-metastatic associated with the liver dysfunction, it can be corrected by doing nephrectomy. So what are the investigations for this renal cell carcinoma? You know, the routine investigations like urine examination for microscopic or macroscopic hematuria you should do. Next, plain X-ray of the abdomen. So long-standing tumor can also produce the calcification. You can easily see in the calcification in the kidney. There is a distortion of the kidney outline by taking a plain X-ray of the abdomen. Next, investigation of choice is intravenous urography. So intravenous urography is also useful to know the functional status of the kidney. Suppose the bilateral renal cell carcinoma is there, which kidney is functioning or not, you can know by doing the intravenous urography or pyelography. Next, high definition of the ultrasound is also very important to know whether it is cystic swelling or a solid swelling, to know the extension of the disease, to know whether it is metastasis to the liver or not, or any other extension in the peritoneal cavity or pelvic cavity. You can assess by doing high definition of the ultrasound scan of the abdomen. Next, CT scan. CT scan is also very important. In what way it helps? To extend the lesion more clearly. At what level the disease has been extended, you can easily find out by doing CT scan. Next, hilar lymphadenopathy. Sometimes may not revealed by the ultrasound. It can be revealed by the CT scan. The involvement of the major vessels like renal vein, inferior vena cava, you can easily find out by doing CT scan. And distant metastasis, either to the lung or bone or liver, you can diagnose by the CT scan. Renal angiogram, pharmacoangiogram. What is the advantage of the pharmacoangiogram? It reduces the vascularity. That means we have to give the solution along into the renal vein. Adrenal should be given. That adrenal normally vasoconstriction. The normal renal vessels are constricted, whereas in involvement of the tumor vessels may not be constricted. So that can blue renal mass can be seen. I will show the diagram. So this is the Graves tumor. This is a blue tumor mass. So bony metastasis. So they have given the renal angiogram. So pharmacoangiogram. There are so many angiograms are there. If the inferior cava is there, you should do inferior venogram or chest X-ray to know any calcification or cannonball secondaries in the X-ray, chest X-ray, and bone scan to know any secondaries are in the bone and pathological fractures. You can identify. These are the investigations is done for the diagnosis of renal cell carcinoma. This is the tumor arising from the kidney. You see, it is also bilateral. CT scan findings. This is the cannonball seen in the chest X-ray of the person who suffered from hypernephroma. Cannonball secondaries in the lungs. Next, sometimes blood examination also should be done. Peripheral smear, hematocrit, ESR, serum calcium levels to be also to be estimated. So hypernephroma, there may be a chance of increasing the calcium, hypercalcemia, or calcitonin can occur. So what are the differential diagnoses? Similarly, polycystic kidney, solitary cystic kidney, neoadrenal tumor, retroperitoneal tumor, carcinoma of the colon. These are the 5 conditions. You can put it them as differential diagnosis. So what is the treatment of choice? The surgery is the only treatment of choice. So radical nephrectomy. Whenever the renal malignancy is there, you do radical nephrectomy. It constitutes the entire kidney to be removed along with the tumor and perinephric tissue and ipsilateral adrenal gland and proximal 1/3 of the ureter. The lymph nodes which lies above and below the diaphragm, from diaphragm to aortic bifurcation. This is called radical nephrectomy. Surgery is the treatment of choice. Sometimes in other, before doing the nephrectomy, you have to first ligate the vessels, inferior vena cava. Why you have to ligate the veins? Because to prevent the emboli formation. So tumor thrombus may be to be removed, and we can prevent the embolization of the renal vein and the inferior vena cava. So if the large tumors are fixed, so only palliative treatment means palliative nephrectomy, partial nephrectomy should be done, or we should debulking the tumor. So whatever the tumor is there, the kidney, if it is not feasible to do radical nephrectomy, in such conditions you have to do debulking or palliative nephrectomy is the treatment of choice. So that what happened, if you remove the tumor, some regression of the secondaries can occur. So similarly, in the Wilms tumor also nephron sparing surgery has done. Here also you should do nephron sparing surgery. Radiotherapy. Radiotherapy is not useful. When you do systemic involvement is there, in such conditions, you should give chemotherapy. What are the drugs to be given? Chemotherapy. One is the vinblastine, interferon, certain interleukins to be given for the distant metastasis. Coming to the prognosis, the surgery may cure 70% of the cases. Survival rate is 3 years. For 60% of the cases, survival rate is 5 years. So what are the prognostic factors? Depending upon the tumor size, involvement of the renal vein or inferior vena cava, involvement of the secondaries, local spread and differentiation. These are the prognostic factors for the prognosis of the renal cell carcinoma. Sometimes you may give adjuvant, neoadjuvant. That means before the surgery or after the surgery. Before the surgery, you have to give the antibiotics. The chemotherapy is called neoadjuvant chemotherapy. Along with the course of the surgery, you should give adjuvant chemotherapy. May be given sometimes. Okay, the other tumors are papillary transitional tumors of the renal pelvis. Just something you should know about this transitional cell tumors. That means transitional epithelium. These are the much less common. Transitional tumor is a bladder tumor. Tendency to intrude the renal parenchyma. Tendency to distant spread. Tendency to multifocal. Seedling down to the lumen causes the multiple ureteric tumors. Carcinogen is a chemical or viral. So what are the clinical features? Patient may have hematuria, tumor mass. What are the investigations? Similarly, same urine examination, breast cytology, and intravenous urography, retrograde pyelography is useful to diagnose the transitional tumors. Treatment is usually a conventional surgical treatment. Nephroureterectomy, if the ureter is involved, you should do nephroureterectomy along with the kidney. Sometimes you should give a short course of radiotherapy before the surgery to prevent the dissemination of the tumor cells. Next, the last one is the squamous cell carcinoma of the renal pelvis. Very rare, associated with the inflammation of the leukoplakia. His tumor is squamous cell carcinoma is more radiosensitive. That's why I have to give radiotherapy. And metastasis at early stage, so prognosis is very poor. This is the transitional tumor. Next class we discuss about the tumors which are related to the ureters. Okay. Hello.
Yes, sir.
Next class we can discuss about the tumors. Hydronephrosis is over for you.
No, sir.
Tuberculosis of the kidney. So next class I will tell about the TB kidney, pyonephrosis, hydronephrosis. Okay. These are the very useful to ask in the examination. After that you will discuss the tumors, ureter tumors.
Okay, sir.
Okay. Thank you.